Good morning, everyone. This is Rebecca Bailey, and I will be the moderator for today's webinar. Welcome to the webinar for November. Our speaker today was recommended as part of our Early Career Investigators Initiative, and we are very, very pleased to have her. And so today's speaker is Dr. and I'm going to mispronounce this, and I'm so sorry, Jiawei Zhou.
Yeah, you're right.
She was actually recommended by one of our former speakers, Dr. Carter Cow, and we were thrilled to be able to bring her on. She is going to present some work that she did with Carter, and both of them will be joining us as part of the Q&A for the webinar. You will be able to ask questions at any point during the webinar by entering the questions into the questions box on your GoToWebinar side panel, and we will be taking all of the questions at the end of the webinar. So Dr. Zhou is a pharmacometrician working at Pfizer. She got her PhD from the University of North Carolina at Chapel Hill Eshelman School of Pharmacy, and a bachelor's degree from Tsinghua, I'm going to mispronounce that, university. And we are so very pleased to welcome Jiawei.
Yeah, thank you, Rebecca, for the introduction. I'm going to turn off my camera here. And today, the topic I'm going to talk about is to understand tumor response heterogeneity in colorectal cancer. And I called it Show the Similarities, Celebrate Differences, because I always believe looking at those similarities and differences across individual lesion would be very important for us to understand this disease. But before I get into the details of those inter-lesion heterogeneity things, I'd like to first talk about some background knowledge about colorectal cancer. This picture, I actually captured it from the most recent published cancer statistics in 2023. And from this figure, we could know that colorectal cancer is the third leading cause of cancer death. The estimated death for the males and females altogether is estimated to be more than 52,000 in 2023. And one of the reasons why colorectal cancer has such high mortality rate is because of metastasis. So the tumor cells on the primary cancer can fall off and travel through the blood or lymph nodes and reach the other organs like liver and lung and form new tumors that is called distant metastasis. When you see a patient with distant metastasis, it's usually indicated that the cancer spreads to other parts of the body already. And for colorectal cancer, more than 20% of patients have distant metastasis at diagnosis. So what's so bad about metastasis for colorectal cancer is shown in the right figure. This figure describes the 5-year survival rate for colorectal cancer by stage. If you look at the top line, it's the stage 1 colorectal cancer patients' 5-year survival. That means those patients don't have any metastasis, and the 5-year survival rate is like more than 90%. And the bottom line is actually the stage 4 colorectal cancer, which means all of these patients have developed distant metastasis. And the 5-year survival rate is pretty low. It's only like less than 20%. The numbers tell us that metastatic colorectal cancer is definitely inflate patient survival. The patients with distant metastasis have very bad survival. And there are a lot of ongoing clinical trials to develop treatments for metastatic colorectal cancer. In the current clinical trial, the RECIST criteria was used to evaluate patient treatment response. So In this criteria, tumor size normalized by the baseline was used to determine if patient respond to the treatment or never respond to the treatment. If you see a patient's tumor size change increase and the increase level is greater than 20%, this patient will be categorized as progressive disease. And if you see a tumor size shrinkage and the shrinkage rate is greater than 30%, the patient will be categorized as partial response. And if patient's tumor size change is not either greater than 20% or shrinkage rate is not greater than 30%, it's like between these two lines, the patients will be categorized as stable disease. And if you see the patient's all of his tumor disappeared during the treatment, we say the patient had a complete response. And what I want to point out about this RECIST criteria is for the patients with multiple metastatic lesions, the RECIST criteria will add all these lesion size together and use the sum of all target lesions to evaluate patient response during the treatment. That came to our questions. We don't know for patients with multiple metastatic tumors in different organs, can the total tumor burden represent each individual tumor response during the treatment? And here we showed an example of a metastatic colorectal cancer patient. This patient was receiving panitumumab plus chemotherapy treatment, and this patient had two metastatic tumors. One was growing in his abdomen, the other one was growing in his GI tract. If, based on the RECIST criteria, we should add these two lesion sets together and evaluate the change of the total tumor burden during the treatment. And obviously, this patient has been categorized as stable disease because his total tumor burden did not have a significant increase nor a significant decrease. However, you will get a very different conclusion if you look at his individual tumor size change from baseline. His abdomen lesion never responded to treatment, and the increase rate is greater than the 20% line, which means his abdomen lesion should be categorized as progressive disease. But the case is very different for his other metastatic tumor. His GI tract tumor had a great response to the treatment, and the shrinkage rate is greater than 30%, which means his GI tract lesion had a partial response. If you only look at his total tumor burden for this patient, you will just say, okay, he is pretty stable. You will ignore those very important information hidden behind his individual metastatic lesion. So this is an example of how total tumor burden is not the sum of its parts. And therefore, here came to the objectives of our study. We want to know for patients with multiple metastatic tumors growing in different organs, will those tumors have similar or different growth dynamics? If they are different, we would ask how much different or heterogeneity exists. And is this level of heterogeneity associated with patient survival? So these are the main three questions we want to address in the study. And here I made a slide to describe our methods. Is an overview of the methods. We basically start from trying to develop some statistical methods to understand those tumor inter-lesion heterogeneity. And after we develop those metrics using statistical methods, we actually found there are some limitations which can only be filled with pharmacometrics modeling tools. And after we applied pharmacometrics tools into the study, we later realized that for the very complex and big data we have, pharmacometrics tools are not enough. That's when we borrowed information or knowledge from machine learning tools to further help us understand the questions. And I will talk about these methods in the latest slides in detail. So the first thing we start with is we are trying to find a statistical way to help us quantify inter-lesion heterogeneity. So we first collected a lot of patient data. We collected like 2,802 patients who all have metastatic colorectal cancer. We collected their metastatic lesion size data. These patients are from 5 clinical trial studies, and among these patients, they are under 6 different treatments. And if you look at this patient as an example, how we quantify his inter-lesion heterogeneity. This patient has 3 metastatic tumors, and for each tumor, we collected the tumor size change from the baseline or like actual tumor size measurements during the treatment. And for each individual lesion, we characterize the lesion response phase, stable phase, or relapse phase. If the lesion showed response during the treatment, we label it as 1. If the lesion showed relapse during the treatment, we label it as 1. If not, we label it as 0. And we also collected the tumor nadir, which is the lowest, smallest tumor size during the treatment. And we also collected the last point measure of each tumor during the treatment. These 5 numbers were used to describe tumor's response or relapse during the treatment. And these 5 variables have been projected into a 5-dimensional space. So basically, each tumor became a point in that space. And the distance between the 2 points in that space can be used to describe how different these 2 tumors responded throughout the treatment. That's when we call that distance, we call them Gower distance. We use the Gower distance as a metric to describe how different each tumor responded from each other throughout the treatment. And in this Gower distance, the higher Gower distance means higher inter-lesion heterogeneity. With these methods, we were able to quantify inter-lesion heterogeneity for all of the patients in our study. And the first thing we did is look at how different each individual lesion responding compared to the total tumor burden. And interestingly, we found more than 60% of patients in our dataset had at least one individual metastatic tumor responding differently from the total tumor burden. So this reinforced our previous assumption that sometimes the whole cannot be well represented by the sum of each individual. We need to look at each individual lesion to understand patient response. The next thing we did is based on the Gower distance we developed. So we separated all the patients in the dataset into 3 groups. The low Gower distance group represented the patients had low inter-lesion heterogeneity. The high Gower distance group represent the patients with high inter-lesion heterogeneity. And based on this survival curve, we can see patients with higher Gower distance or higher inter-lesion heterogeneity had worse overall survival. And these kind of correlations have been confirmed within the Cox survival models after accounting for other confounding covariates. So from this picture, we could conclude that heterogeneity is associated with survival in metastatic colorectal cancer. And to further understand where those heterogeneity came from, we selected the top 3 metastatic organs in the dataset. They are liver, lung, and lymph nodes. And in these 2 figures, we compare for those lesions are receiving panitumumab plus chemotherapy with those lesions receiving chemotherapy only. And we look at those lesions nadir and Gower distance. So if you look at the left side compared with right side, you could see the tumors under targeted therapies have significantly lower nadir compared to the lesions under chemotherapy only. which means targeted therapies showed better efficacy. And another thing I want to point out is if you look at the liver lesions, nadir, and Gower distance, and compare that with lung and lymph node metastasis, we can see liver lesions under targeted therapies have significantly lower nadir and Gower distance compared to the tumors growing in the lung and lymph nodes. However, under chemotherapy only, these comparisons are not statistically significant. This comparison indicated that targeted therapies favored metastasis in the liver. And and we also want to know if this kind of metastasis in different organs have impact to patient survival. So we did a survival comparison for those patients with either liver, lymph nodes, or lung metastasis. So let's look at this survival curve first. So in this plot, we included all the patients who have metastasis in the liver. They can also have metastasis in other organs, but our focus is they all have liver metastasis. And the top yellow line are those patients, all of his metastatic lesions responded to the treatment. And these black lines are the patients who all of his metastatic tumors did not respond to the treatment. Obviously, the yellow line patients have significantly better survival than black line. But that's not our focus. We would like to focus on the lines in between. So this red line, these red survival curves, are those patients whose liver lesions responded to the treatment, but other organ lesions did not respond to the treatment. This blue curve are those patients whose liver lesions did not respond, but other organs respond to the treatment. Very interestingly, the red curve patients whose liver lesions responded to treatment have significantly better survival than those patients whose other organs respond to the treatment, but liver did not respond. And we are wondering if this is consistent with other organs. And in lymph nodes and lungs, we see actually the opposite correlations. In this figure, we can see the patients whose lymph nodes responded to the treatment have worse survival than patients whose other organs responded to the treatment, but lymph nodes did not respond. And that is the same for lung. So from this survival curve comparison, we could see liver lesion responses are more relevant to patient survival than lymph nodes and lung. So far, we could conclude that in this study, we realized that we found inter-lesion heterogeneity exists in metastatic colorectal cancer patients, and we developed a Gower distance to quantify that inter-lesion heterogeneity. Patients with higher Gower distance have worse survival, and liver lesion responses is more correlated or relevant to patient survival. But this study also has some limitations. First, how to calculate Gower distance. All of the metrics we used are based on the observed tumor measurements during the treatment. We use those observed tumor measurements to determine tumor response and the relapse time and treatment efficacy. But how about those tumor size change between the two sampling time points? The patients were not measured, but it doesn't mean the patient's tumor size were not changing. And the second thing we want to know about is a lot of patients drop out from the trial, either because of disease progression, because of death, or because of they could not tolerate drug toxicity. But we lost the follow-up measurements does not mean the patient's tumor won't relapse after the treatment. So we only look at the observed tumor measurements in this study, and we did not look at those during those time when patients were not measured. And the second limitation is we only look at the top 3 metastatic organs in this study, liver, lung, and lymph nodes. But for the other organs, like brain, like bone, because we did not look at them, it's not because they are not important, but it's because they don't have enough numbers for us to make statistical comparisons. So we ask ourselves, how about the other metastatic organs? How can we look at them as well? And the third thing is we have learned a lot of knowledge from previous studies, but how can we better apply that in the real clinical treatment to help physicians to better determine what treatment can be used for colorectal cancer patients? How can we use our knowledge to better prolong patient survival? So that's when we decided to borrow the knowledge from pharmacometrics model. So pharmacometrics tumor growth model can help us not only look at the observed data, but also make the predictions of the whole tumor growth pattern during the treatment and even after the treatment. So we first collected tumor metastatic lesions information from 4,308 metastatic colorectal cancer patients. We collected those individual tumor size measurements and the patient survival data. And after we collected this observed in each individual lesion data, we developed a tumor growth model. In this model, the parameter KD represents the tumor regression rate. The parameter KG represents the tumor progression rate. And parameter F represents the tumor non-responding fraction. And with this model, we are able to predict the whole tumor growth dynamics, not only during the treatment, but also after the treatment. In order to fit this model with this large number of data, we applied nonlinear mixed effect estimation method. That is because there are a lot of patients in our data set have very sparse sampling data. And this method allows us to accommodate those sparse sampling patients with the population level information. And this method allows us to get each individual lesion parameters. So with each individual tumor parameter estimated, we can use the model to predict the tumor growth patterns for all of the lesions in our dataset. And with this model, we are able to accurately capture the response time and the relapse time for all of the tumors in our dataset. After we got each individual tumor parameters, we first compiled the correlations between those parameters. Unfortunately, we didn't see any correlations at each individual tumor level. That's because there are a lot of variabilities and we have a lot of tumor in our dataset. But interestingly, we see the model parameters correlations at lesion level. So we summarized tumor parameters by organ and used the median to make these plots. So in this correlation plot, we can see the model parameters have correlation at organ level. In fact, the KD, the regression rate, is negatively correlated with patients' non-responding tumor fraction parameter with F. And KG, which means the progression rate, is positively correlated with F. And the KD and KG also have some correlations. So this is very interesting because when you see from each individual lesion level, you did not see the correlations. But when you see from organ level, these parameters are correlated from each other. And the next thing we did is we have each individual lesion response time and progression time from the model predictions. We translate them into response and progression probabilities, but by organs. We rank those organs response probability and progression probability from high to low. You can see across all of the metastatic organs, the tumors in the liver have the highest response probability, and the tumors in the brain and CNS have the highest progression probability. In order to better understand this ranking, we translate these two rankings into a 2x2 matrix or organ chart. In this plot, the x-axis are the relapse or progression probability from low to high, and the y-axis are the tumor response probability from low to high. So in this chart, all of the organs were separated into 4 sections. And I would like you to look at this section of organs first. So bone, brain, muscle, soft tissues are all included in this section. And we call these organs bad organs because tumors growing in these organs have very high relapse probability, but very low response probability. And we are wondering if this is correlated with patient survival. So the next thing we did is we separated patients into 2 groups. The first group of patients who don't have metastasis in these bad organs, and the other group of patients have metastasis in these bad organs. And the patients who had metastatic tumors growing in these bad organs have significantly worse survival than those who don't. And the next thing we want to look at is this section. We call them good organs. Lymph nodes, spleen were only included in this section, and the tumors growing in these organs have low relapse probability, but high response probability. And similarly, we separated patients into 2 groups. This group of patients only had metastatic tumors growing in these good organs. And this line of patients represent the patients who not only have metastasis in these good organs, but also metastatic tumors in other organs. And the patients who only had this good metastasis have significantly better survival than those who also have tumors growing in other organs. So from this comparison, we could see some organs have higher, tumors growing in some organs have higher response probability. In some other organs have higher relapse probability. And we want to know if this kind of correlations, organs level similarities or differences only exist in metastatic colorectal cancer, or it can be applicable to other tumor types. So we did exactly the same analysis, but to a different tumor type, metastatic head and neck squamous cell carcinoma. So in this tumor type, the patient number is totally different from metastatic colorectal cancer. The metastatic organ types are also different, but we find some similarities between the 2 charts. So if you look at brain, the metastasis in brain for this tumor type also had high progression probability and low response probability. And lymph nodes are also still fall in the good category, which means the tumors growing in lymph nodes have high response probability and low relapse probability. And the liver, the tumors growing in liver for this type of tumor still fall in this category as metastatic colorectal cancer. So this consistency in these 2 organ chart actually indicated that this organ chart might be applicable to other types of tumor. Another interesting question we were asked a lot is about treatment. How treatment have impact on organ level response and progression probability. So based on the previous analysis, we add one more stratification by the treatments. We separated patients by the treatments of chemotherapy only or targeted therapies plus chemotherapy. And we found the targeted therapy treatment do not have any significant impact on organ level response probability, but the targeted therapies can significantly reduce tumor progression probability. So from this comparison, we could see targeted therapies primarily decrease lesion relapse or progression probability. So after the previous analysis, we further understand the organ level similarities or differences. And we are wondering, how can we apply that to clinical applications? The first thing we want to know is For patients with more than one metastatic tumors, we have already know that each tumor may have very different growth dynamics. That means each tumor will have a very different relapse time. And for this patient specifically, he had 3 metastatic tumors in his liver, lung, and GI tract. And based on the model, we could find the relapse time for his individual tumor. And for this patient, he had a relapse sequence. The first tumor relapse happened in the liver. The second tumor relapse happened in the lung. And the third tumor relapse happened in the GI tract. And for this patient, he has his unique relapse sequence as liver, lung, and GI tract. And for the 4,000 patients in our dataset, each patient had different metastatic organs and will have his unique relapse sequence. And can we find some similarities or patterns across this relapse sequence? And we want to know if this relapse sequence influences patient survival. That's when we realize that the traditional statistical methods or pharmacometrics methods are not enough to answer these big data and complex questions. So we borrow the knowledge from machine learning. So there is a method called k-means clustering method from machine learning that help us classify patients into different groups based on the similarities of their relapse sequence. And as a result, 5 clusters of patients were identified in our dataset. And we presented their relapse sequence using heat map plot. So in the column of heat map plot here represent the sequence of lesion had relapse. For example, 1 means the first relapsed organ, 2 means the second relapsed organ. And each row of the heat map plot represents a different metastatic organ. If you look at the first picture, we call this group lung first because all of the patients in this group had their first relapse happen in the lung. And if you look at the second picture, we call this group liver first because all of the patients in this group had the first relapse happen in the liver. And this group of patients, the first relapse happened in all of the organs except for liver and lungs, so we call them other first. And this group, all of the patients only had 1 tumor relapse during the treatment, so we call them mono-organ. And this group, multiple organs had relapse for the group of patients, so we call them hetero-organ. And we compare the survival of these 5 groups of patients. Obviously, we found the patients who had multiple organ relapse during the treatment had worse survival than the patients who only had 1 organ relapse. And for those patients with similar relapse organ number, liver first patient had worse survival than other first and liver first. So from this analysis, we could tell that the relapse sequence is associated with patient survival. After we find all the patients could be classified into 5 groups based on their relapse sequence, and we also know relapse sequence is correlated with patient survival, we're wondering how can we apply this knowledge into the real clinical treatment. We hope to predict patient cluster at the time of diagnosis. So when a patient with metastatic colorectal cancer came into the clinic and got diagnosed, can we develop some models to tell us what cluster this patient belong to? If this patient, for example, can be predicted to be liver first cluster, then the physicians could know immediately that this patient we need to specifically care for his liver metastasis because it's very likely that his liver metastasis will relapse first, and that will make the patient have worse survival. So some liver-specific treatment should be recommended to this patient to prevent their liver metastasis relapse. And that's when we realized machine learning models can help us develop to make these predictions. So we use a machine learning model called gradient boosting model. And what we did is we used all of the patient's demographic information and clinical characteristics at the time of diagnosis. We let the machine learning model study those information and study what categories these patients belongs to. So the model could find a correlation of patterns to using those baseline demographics and clinical characteristics to classify what cluster this patient should belong to. And this is the result of our predictive model. We built a gradient boosting model to predict patient relapse sequence category. And the information we used are only patient baseline clinical characteristics. And in this plot, the AUC under the ROC curve is 0.91. When this AUC under ROC curve is greater than 0.9, it means the model have good performance in the prediction. So our curve is like 0.91, which means our model can have good performance in predicting which category this patient should belong to. And that is the last slide of my presentation. What I want to point out is from statistical methods to pharmacometrics methods to machine learning methods, what we are trying to look at is using those computational and mathematical methods to help us understand inter-lesion heterogeneity. We realize there is a high inter-lesion heterogeneity exists for some of those metastatic colorectal cancer patients. And for those patients, every lesion matters. And across all different organs, we realize liver lesions response are more relevant to patient survival. So liver lesion matters more. We created a chart to tell those organ level similarities and differences. We realized that organ level relapse sequence is associated with patient survival. And interestingly, we found patients with first relapse happen in the liver often had worse survival than those patients whose relapse happened in the lung or other organs. So in the end, I would like to make some acknowledgements. First, I would like to thank this website called Project Data Sphere. All of our clinical trial data were obtained from this open data website. I would like to thank those sponsors who put their clinical trial data on this website to allow all of the other researchers to study and done those investigations. And I would like to thank UNC and Pfizer for the support. I would like to thank all of our collaborators. I specifically would like to thank my PhD supervisor, Carter, who inspired all of this work. And I would like to thank Rosa Webinar to give me these opportunities to do this presentation. And all of the work I mentioned are published on these two papers. I will share the reference of two papers after the webinar. So that is the end of my presentation, and I'm happy to address any questions.
Thank you for an absolutely wonderful webinar. We do have some questions, and for our audience, you can ask questions simply by entering them into the questions pane on your GoToWebinar side panel. So let me start with some of the first questions. Were you able to determine what features had high predictive performance?
I think in my machine learning models, we were able to find out which factors weighed more than the other factors. And if I remember it correctly, I think baseline tumor burden in different organs matters most. And I think that makes sense because when a patient first come into clinic, although it's not very clear correlations for colorectal cancer that the size is correlated with the future relapse or response, but when the patient first come to the clinic, he already have metastasis in the liver or in the lung, those tumors are more likely to relapse, that is for sure. So I think that is why the baseline tumor burden in different organs can be a very important weighting scale, weighting factor in the model predictions. But I have to say all the other clinical demographics like age, gender, those definitely will be help with the predictions.
Do you think that the patterns of organ level relapse sequence are true just for colorectal cancer, or are there parallels in other cancers?
Yeah, I think that is a very good angle. So we did try to validate the organ chart, like the response and relapse probabilities in other organ types, but we did not try to validate the relapse sequence in other tumor types. But that's something that definitely will be very interesting to look at. One challenge would be in some of the tumor types, they don't have enough data, or some of the tumor types, they have limited metastatic organ data available. So that could bring some bias when you want to compare those relapse sequence with colorectal cancer. But I have to say that is a very interesting point to worth to further look at.
Have you checked to see if the patient stratification, liver first, etc., also correlates with specific tumor mutations or gene signatures in the lesions?
Yeah, I did have the KRAS mutation information to add. I tried to add that information into our predictions and into our investigations. Unfortunately, all of the data we had are the clinical trial data 10 years ago. So the sponsors put their data, only chose to put their old study data into this open website. So in those old data set, not many genetic mutations were detected, and not even KRAS mutations were detected for all of the patients. So basically, we missed a lot of KRAS mutation information in a bunch of patients. So unfortunately, we were not able to include those genetic or epigenetic mutation information in this study. If we could have more data in regards to the genetic mutation information, that will be very interesting. And I do believe that will be a big factor in this kind of survival comparison.
So this next question has two parts. Let me give you the first one. Are you using the 5 clusters as classes for classification task?
So in the clustering method, we use unsupervised machine learning clustering method, and basically we try to classify it from group 2 to group 10. And we compare different classifying which clustering method makes more sense. How we determine the 5 clusters in the end is a discussion between machine learning models, performance, and clinical implications. Our goal is to separate patients into several clusters that are not only well separated based on their relapse sequence, but also have clinical implications. So after we try different like 4 cluster, 5 cluster, 6 cluster, 7 cluster, we look at them individually and we realize the 5 clusters have most clinical implications, and we compile those different clusters and we realize actually the first relapse organ can make a difference. So that's why we chose 5 clusters in the end.
Do these clusters have any clinical or physiological meaning?
I do believe they have. So we named them after, like liver first, other first, lung first. We named them after the first relapse organ, but we presented the whole population relapse sequence in the heat map plot, because we do believe it doesn't mean the second relapse organ is not important. It's just a mean we saw the first relapse organ immediately, and we named them after it. But if we look at the whole heat map plot, The second relapse sequence were also presented in the figure. The third was also presented in the figure. And definitely that means a lot to us. But we are still looking for some better ways to interpret these patterns and associate them together with the clinical meanings. And I do believe there are more machine learning tools that can help us better look into those figures into a deeper perspective.
So I think we have two questions that are very similar. I'm going to read you the first one. How did you account for PK or tissue distribution considerations, especially for tissues with poor distribution like the CNS, when comparing the severity of different tissue metastases sites?
I definitely think PK is a very important factor in those anatomical charts. So some organs have good response, some organs have worse response. I think two factors are the factors we are very interested in. One is PK, one is immune microenvironment. So from the PK perspective, you can see some like the organs like brain, bone, those organs well, drugs are more difficult to penetrate in. They have worse, they have like lower response probability. So this makes sense that these organs, the drug couldn't get in, the tumors won't respond. And for the organ like liver, that's how the drug can easily penetrate in. They have very good response in both colorectal cancer type and head and neck cancer type. So this definitely means this organ chart can be correlated with PK. And another important factor we are looking at is tumor microenvironment. The immune function of that organ can have some impact to the tumor relapse. So if this organ has some strong immunofactors like lymph nodes, the immune cells, T cells, B cells can exist a lot of in those organs. The tumors are less likely to relapse. But if you look at liver, the tumor are more likely to relapse. So I'm thinking about both PK factor and immunology knowledge should be combined together to understand that organ chart. But if we want to confirm those correlations with PK or immune functions, we definitely need further study to help us confirm that associations.
I'm going to read you this next question. It's a little long. For the RECIST criteria in slide 12, is there any lesion or patient that has a response in the beginning, but tumor rebound later? That is, the patient might be categorized as PR first and PD later. And when you're comparing the survival outcomes between the groups, do you consider the longitudinal response results?
Yeah, that's very common to evaluate a patient. A lot of patients respond very well at first and were categorized as partial response. However, the tumor developed resistance to treatment, and you can observe a later relapse, and they were later be categorized as progressive disease. I think there are a lot of cases in this kind of studies. But in this study, our focus is on the inter-lesion heterogeneity. So when you use the total tumor burden, you might see this kind of change, but you may not be able to see this kind of change as well, because like the case I showed, for one of the lesions, it had a relapse, but if we look at the total tumor burden, the whole total tumor burden remains stable. So for those patients, sometimes you may ignore their individual lesion relapse. I think for the RECIST criteria, it has been a very good golden standard to be used for solid tumors. And with the more focus on patients' individual lesions and with more novel modalities or treatments come through in, the RECIST criteria will evolve as well to help us determine like which tumor should we put more focus on and help physicians to determine if you see in a patient one tumor relapse, one tumor response, what should you do to this patient? Should you continue the treatment, or should you stop the treatment and change a different drug? So that is the goal of this study. How we are trying to see this issue. Yeah.
Can you explain how pharmacometrics contributed to identify the heterogeneity? Or does it
So
only help to estimate parameters?
why we decided to borrow pharmacometric tools is because we realized that statistical tools can only look at the data you measured, but pharmacometric models help you make the predictions of the whole trajectory and also borrow the information from the whole populations to understand each individual tumor. So if you just have the model but did not fit it with nonlinear mixed effect estimation method, you will get a lot of weird parameters, and you could not get realistic predictions for those tumors because a lot of subjects or tumors have very sparse sampling data, maybe or 2 or 3 data points. So that is how we borrow the knowledge from pharmacometrics to help us look at this issue. And I believe with more data come in, like PK data, biomarkers data, PD data, this kind of analysis pharmacometrics tools can be a more important tool to be used in this kind of case if we have more data to come in. And for the current phase, I think combining pharmacometrics tools and machine learning tools can give you unexpected good results, surprising results to tell you something you can never be told by your eyes or statistical methods. That's how I feel about pharmacometrics tools.
Did you analyze non-target lesion progression? And if so, what kind of signal?
Yeah, I did. So in the later analysis, we have total of more than 40,000 lesions. This number included both target lesions and non-target lesions and new lesions. For a lot of non-target lesions, the tumor size measurements were not recorded in the data set. We only have information about when the tumor was observed relapse. We only have that information, or we only have the tumor was categorized as partial response. We only have that limited information. And for the new lesion, we only had when the new lesion come out. So we use that as information in our later response probability and progression probability analysis. So for the target lesions, we use model to calculate the response time, progression time to calculate the response and relapse probability. And for the non-target lesions, we use their categorical response results to calculate their response and relapse probability. And for the new lesion, we assume that is we only accounted it for the analysis for relapse because we assume the time it appears is the time of that lesion relapse. So we basically make that directly transformation to calculate our response and relapse probability.
So can you tell what software you used for the machine learning?
We use Python for the machine learning. I think there are a lot of well-established Python packages to perform clustering and gradient boosting model.
Were you able to explore the heterogeneity of response of the liver metastases to, I'm going to mispronounce this, sorry, bevacizumab? It's one of the targeted drugs.
Oh, okay. So in our data set, the targeted therapy treatments we had data with is panitumumab, bevacizumab. Cetuximab, unfortunately, we don't have that data. So we stressed in our work that the limitation of this organ chart is our results we only analyze the treatment we have in the dataset. For the other type of treatment, for other immunotherapies or like in the future new therapies, we are not sure if these results can be applicable to other treatments. But one thing we believe is our methods, the workflow we build with this statistics, machine learning, pharmacometrics, the workflow we build can definitely be applied to analyze other treatment data.
So do you have any idea why the liver stands out in terms of time of relapse probability? Why is the liver
That's some
different?
yeah, that's a very good point. So I'm not sure why liver stands out for colorectal cancer, but one of the reasons I presume is colorectal cancer is very easy to metastasis to liver. And liver is an organ that very easy to grow metastasis in. So that's why liver also stand out in a different type of tumors. I think liver is a very important and complex organ. It has a very different drug distribution and penetration features. It also have a very different immune microenvironment than the other organs. So it's definitely worth to look more into why liver metastasis have such a different growth dynamics compared to the other organs. Why liver stands out? That's a very interesting topic to worth to look more into.
Thank you. This has been really interesting. We just have a couple of questions left. And you had mentioned essentially brain, lung, and lymph node. Were there any other organs that had a significant impact in your analysis?
I believe bone, brain are very important to look at because they have worse drug penetration and also very easy to cause tumor relapse. And lymph nodes, distal lymph nodes, regional lymph nodes, lung are also very important. And besides that, other organs, I won't say they are not important, but they just didn't stand out in this analysis. But I believe for different type of tumors, you may see other organs stand out that you should pay attention to. And for the physicians, for different type of tumor, for different organ of metastasis, they should have different ways to provide treatment for the patients.
And is this work going to be continued with other tumor types?
I hope so. I hope to see if this kind of organ chart can be extrapolated to other different type of tumors. And I hope to see this kind of analysis be applied to other treatment interventions like immunotherapies to see how those organs under immunotherapies had different or similar relapse or response patterns.
And then we have time for just one final question. When you looked at the pharmacometrics modeling, was one particular parameter the most important for predicting survival?
I would say KG, the progression rate, that is very important. For the organs that did not respond very well but are less likely to relapse, it should not be a problem to worry about compared to those organs who are very easy to relapse, although they are very easy to respond. So I would say definitely KG should be a parameter that is more associated with patient survival. However, we never compare those parameters directly with the survival. So I cannot give you a sure answer about how much correlations they are correlated. My answer is just from a general understanding of that model.
Okay. And I'm going to sneak in one final question. How about would you use these same methodologies for rare cancers? Um,
This is something I never thought about. I don't know, like for the real cancer, I believe the sample size are smaller, and we have less information about what organs of metastasis they have, and the treatment information, how the drug penetrated to different organs may be less studied. So that is something we can definitely explore in the future.
we are out of time, but this has been an absolutely fabulous webinar. I'd like to thank our speaker, and I'd like to thank Carter for recommending her. We are so pleased you came today, and we hope that you can come back at a future time and present another webinar if possible. And we hope that everybody on our audience can come back and join us again. Thank you so much.
Thanks everyone for joining, and special thanks to Carter, who inspired all of this great work.
Have a great day, everybody, and hope to see you again soon.